Nikita, Dr. Sani is saying
Dr.
something.
Nikita, we can't see
Yes,
the
sir.
slide. Yeah, now I can see the slides. There was a gap.
So
There
what
was a
you're
gap period.
possibly you're under the pressure of 20 minutes. Don't rush through your slides. Take your time.
Okay. Yeah.
When we say 20 minutes, don't worry. We can extend it by 5 to 7 minutes. Don't rush through your slides. Go slow.
Okay, sir. In the past history, patient is hypertensive, diabetic, and hypothyroidism. In 2012, patient was treated with interferons as direct-acting drugs was not available that time. In 2015, ultrasound abdomen diagnosed as chronic liver disease, and during that time, upper GI endoscopy was done, which shows esophageal varices for which EBL was done. 2019, diagnosed as hepatocellular carcinoma in DMC Ludhiana, the microwave ablation was done. During that time, the left lobe was involved, no portal vein thrombosis, and also there was lesion 3.5 into 2.7 into 2.5 centimeter along the posterior margin of the gastric body, suggestive of GIST. Alpha fetoprotein was normal that time. Patient initially started on sorafenib. After 7 to 10 days, patient start complaining of a redness and blisters on the bilateral hands, which is suggestive of query of hand-foot syndrome, sorafenib induced. After that, patient lost follow-up due to COVID pandemic as she was asymptomatic. Patient revisited to DMC Ludhiana for further treatment and advised to start lenvatinib 8 mg in November 2020. The patient went to Tata Memorial Sangrur for second opinion, reevaluated the same. They did 3 liver aphanesia and biopsies, which are not suggestive of any malignancies at different hospitals. In May 2021, gastric biopsy suggestive of GIST, and patient was started on imatinib. During that time, patient was not taking any systemic therapy for the HCC and planned for resection later. Endoscopy shows a small esophageal varices and portal hypertensive gastropathy. The GIST wedge resection done in September 2021. There is no past history of any blood transfusions and jaundice in the history and tattooing. Personal history, patient is vegetarian by diet. There is a calorie intake now is 1450 kilocalorie per day. The appetite is decreased. There is no addictions. Sleep cycle is normal. Regular bowel and bladder habits. Family history, there is no history of any gallstone, anemia, liver disease, maternal hepatitis B, HCV, and malignancy. Patient belongs to upper middle class according to a Kupuswamy scale. The case summary according to the history, the patient is 54-year-old female with known case of hypertension, diabetes, chronic liver disease, post-TVL, and post-microwave ablation for HCC, presented now with a chronic visceral pain with significant weight loss with no history of a jaundice, fever, or GI bleed. So my diagnosis is pointing towards the malignancy, as patient has history of treated hepatitis C in 2012 and 2015. Patient diagnosed as as chronic liver disease and during that time the post-EVL was done. In 2019, the patient had microwave ablation. My diagnosis is pointing toward HCC as a recurrence, why the abdominal pain accounts for 60 to 90% in the case of HCC, that is dull aching as in my patient, and there is also a history of a weight loss which accounts for 34 to 70%, and weakness is 20 to 50%. So my diagnosis is pointing towards provisional diagnosis is HCC recurrence. Microwave.
Nikita, I can't hear you. There's no sound. Nikita, there is no sound.
I think we have lost connection with Dr. Nikita. Dr. Nikita, if you can you just stop sharing your video?
Median free survival of youngest who radiotherapy is positive is abdominal pain in the case of PS stomach, and second is the weight loss. But the negative history.
Dr. Nikita?
Dr. Nikita, could you go back on the previous slide, please, on the HCC recurrence, Dr. Nikita? Dr. Nikita? Dr. Nikita, could you go back on the previous slide of HCC recurrence, please?
Dr. Arvind, Kindly give a few moments. I think there's a connectivity issue. Dr. Nikita, please stop sharing your video first. There's a connectivity issue at your end. So I request you to stop sharing your video.
If you stop sharing your video, even with a low.
Yes. Now click on slideshow.
Go to slideshow.
Go to the previous slides.
मीटिंग में बेसिक 1 घंटा में बस वो ये लिखना है कि
So which slide?
The second slide on HCC recurrence, your first differential diagnosis, the second slide, could you, after this slide, please explain in detail, yes, about the recurrence rate. Yeah, the slide previous to that, the slide before the CA stomach. Yes, no, the slide after this, the slide after, yes. Can you please read it out? Not this one, the next slide. The next slide. Yes, this slide. Dr. Nikita, can you read it out?
I'm keeping the differential diagnosis of CA stomach as second. As patient having a abdominal pain.
Can you go back to the previous slide?
The previous slide. Yes.
Okay, start from here. Okay, start from here.
I'm keeping my first diagnosis as a HCC recurrence, as patient is already known case of chronic liver disease with post-microwave ablation in 2019 for HCC.
Yes, okay, go on.
Patient is complaining of abdominal pain, which is accounting for 60 to 90% in HCC, and having a weight loss is 34 to 70% and weakness of 20 to 50%. The microwave ablation has a local recurrence rate of 8% and having a median recurrence-free survival of 18 months. The risk factors include the younger patient, the patient who earlier treated with the neoadjuvant chemotherapies, and those who are having alpha-fetoprotein levels high.
Yes.
My second possibility is CA stomach. The negative history pointing towards CA stomach is there is no postprandial worsening. There is no acid peptic disease like symptoms. There is no symptoms of any gastric outlet obstruction. The third DD is a CAGB, as it is more frequent in a female. The male to female ratio is 1:3. The patient is having a right hypochondric pain, that is 80%. Anorexia plus weight loss is 75%. The negative is patient is not having any past history of recurrent biliary colic due to gallstone, and there is no history of any jaundice. The diagnosis, the benign differential diagnosis can be peptic ulcer disease, abdominal tuberculosis, chronic pancreatitis, and chronic mesenteric ischemia. On general examination, the patient is conscious, oriented to time, place, and person. The BMI is 32.5, that is class 1 obesity. Patient is moderately built and nourished. Afebrile, the pulse rate is 76 per minute regular. The BP is 130/80 in a right supine position. The respiratory rate is 18. The neck veins are not engorged. Thyroid is not enlarged. There is no pallor, icterus, cyanosis, clubbing, peripheral lymphadenopathy, and edema. Hair and eyes and oral cavity are within normal limits. On systemic examination, the abdomen inspection, abdomen is globular, umbilicus central and inverted, flanks are empty, 2 centimeter scar present below umbilicus, most probably the just resection mark of laparoscopy. Skin stretch marks are present. There is no dilated vein, sinuses, visual pulsations, visible mass, visible peristalsis, any hernial sites. All the quadrants are moving equally with respiration. On palpation, superficial, the temperature is normal. There is a mild tenderness present in a right hypochondric region. There is no guarding and rigidity. On deep palpation, the liver is palpable, 2 centimeters below the right costal margin. The It is firm in consistency and regular margins. The GB, spleen, and kidneys are not palpable. Percussion, it is tympanic all over the abdomen. The upper body of the liver dullness is fifth intercostal space on right midclavicular line. There is no shifting dullness. On auscultation, the bowel sounds are normal. There is no bruit or there is no venous hum. Rectal examination, the anal tone was normal. There is no palpable mass, and other systemic examinations are within normal limits. On initial clinical workup, the alpha-fetoprotein is 64.7. Patient belongs to child PUG A. The platelet count is 1,80,000. The bilirubin is 2.2. The albumin is 3.6 and INR is 1.2. There is no hepatic encephalopathy. Ascites was not present. MELD sodium is 40 and hemoglobin is 12.2. On ultrasound, which was done outside, liver is 11.5, diffusely coarse liver ecotexture, suggestive of chronic liver disease changes, and also there's an occlusion of a portal vein at porta with splenomegaly and GB sludge. Endoscopy was done, which shows two small esophageal varices with severe portal gastropathy. The triple phase CT was done in our institute, which shows a liver in a normal size, shows an irregular lobulated outline. There is relatively a hypertrophy of a caudate and left lobe. On a portovenous phase, there is a presence of a hypodense filling defect in the left portal vein, which I'll show later in the CT films. Small focal filling defect is also seen in the right branch of the portal, which is suggestive of thrombosis. The main portal vein is 16.3 mm at porta. The splenic vein is replaced by the multiple collaterals. This is CT image, which is showing the main portal vein. The right is having a thrombus. On the left side, there's a bilateral portal vein thrombosis present. And there is a caudate lobe and left lobe hypertrophy is also seen. There's an altered ecotexture of a liver.
Can we see the CT
Is I'm
scan,
audible?
please? No, can we see the CT scan, please, Dr. Nikita? Yes. Can you show detail? Just explain. Can you show the CT scan with portal vein thrombosis, please? Yes.
Yes, sir. This one.
No. Yes, this one, please explain.
This is the main portal vein. And there is a big thrombus in the right portal vein and also the left side of the portal vein, both anterior and posterior. There is also a hypertrophy of left lobe of liver. A study estimated time for a tumor thrombosis that is present in the second portal branch to grow into an ipsilateral first portal branch. From the first portal branch to a main portal branch is only 8.5 and 11.5 days respectively. The extent of PVTT itself is an independent risk factor for the rapid progression of tumor thrombosis, although with the performance status and the ascites have a significant impact on the patient's survival and the choice of therapeutics. This is also an image which shows a heterogeneous soft tissue mass abutting the fundus and the greater curvature of the stomach.
Okay.
The histopathology of liver and the stomach biopsy, which was done outside, was reviewed by our pathologist, which shows a stomach lesion is suggestive of just a spindle cell shape and IHC tumor, which are positive for CD34 and CD117 and DOG1. These are the spindle cell arranged in a fascicles. These all are spindle cell, and this mitosis is marked by the arrow. Liver biopsy is done in our institute too, and the reviewed slide was also done. The liver biopsy shows a distorted hepatic architecture, a mild stenosis, and focal feathery degeneration and regenerative changes. There is some foci of necrosis and spindle cell arranged in fascicles. In correlation with the morphology, initially we thought the patient is having a lesion of metastatic origin from the stomach, from the chest. but the IHC code suggestive of malignant neoplasm, the feature consistent with the hepatic cellular carcinoma. There is a round to polygonal tumor cells which are arranged in thick tabulae in the nest. There is a mixed micro and macrovascular stenosis and biliary duct proliferation. These are the thick trabeculae as marked by the arrow, and this big arrow is marked the nuclear pleomorphism, and the thin arrow is marked the inclusion of the hepatocytes. My final diagnosis after physical examination, history, and detailed investigations, I come to a diagnosis of decompensated cirrhosis of liver, likely NASH related, as patient is hypertensive, diabetic, and obese, the metabolic syndrome. And the second probably should be considered as hepatitis C related. Portal hypertension with small esophageal varices with portal hypertensive gastropathy, having a MELD sodium of 40 and child PUG A, advanced HCC, Bclc stage C, microvesicular invasion involving the both right and the left branch of portal vein, the performance status ECOG 1, the gastric just low risk. There's a synchronous HCC and just hypertension, diabetes, and hypothyroidism. This is a rare case presentation of a synchronous HCC and gastric gist. Gastric gist are the rare mesenchymal tumors of GI tract. They are identified as an interstitial cell of Cajal. The 75% are spindle cell shape. The distinct metastases of gist are predominantly in the liver and the peritoneum. According to NIH Fletcher criteria of gist risk, my patient come under low risk. The R0 resection was done. The 5-year overall survival of isolated liver metastasis of gist with hepatectomy is about 50%. However, the recurrence rate following a surgical resection for the hepatic metastasis from the gist was reported as 70 to 77%. A case of advanced unresectable HCC is considered for the first-line systemic therapy, which includes the atezolizumab 1200 mg plus bevacizumab 15 mg per kg every 3 weeks. The most adverse reactions leading to the death was gastrointestinal and esophageal varices, hemorrhage, and infections. If not feasible, we can put on sorafenib, and the data suggestive lenvatinib has a high response rate as compared to other tyrosine kinase inhibitor. This is a paper from Anigium article, which is showing about atezolizumab plus bevacizumab in an unresectable hepatocellular carcinoma. They have shown the overall survival at 12 months was 67.2% with atezolizumab plus bevacizumab, and with sorafenib it is 54.6%. So the conclusion said the patient with an unresectable HCC, atezolizumab combined with the bevacizumab resulting in a better overall and progression-free survival outcome than sorafenib. Also, my patient is suffering from a hand-foot syndrome, most probably that is sorafenib induced. Why I'm putting this slide that sorafenib induced blistering and painful callosities over the palm and sole are not a contraindication for the cessation of therapy, thus highlighting a dose-related cutaneous side effect of sorafenib. They can easily treat it by application of corticosteroids and clobetasol. The second line is regorafenib, cabazitaximab, ramucirumab. REACH trial only recommended when the alpha-fetoprotein level is more than 400 nanogram or equal to 400 nanogram per ml. This is Bclc staging and treatment strategy. As according to that, my patient will come under advanced stage C with a portal invasion and with a performance status of 1. The systemic therapy should be started, including atezolizumab or bevacizumab. If not feasible, then sorafenib or lenvatinib. The second line is regorafenib. In case of in late stage, as my patient is having a Bclc, the TARE may offer a better quality of life and better visits to a hospital than TACE. TARE has a specific role in inducing a contralateral lobe hypertrophy and a downstaging to a liver transplantation and can be used as an alternative to TACE ablation, surgical resection, or sorafenib. Thank you, sir.
Thank you, Dr. Nikita. That was a very good presentation. Nikita, before I open the session, I would like you to clarify the difference between a portal vein tumor thrombosis and a simple portal vein thrombosis in a CLD patient. What are the differences? How will you differentiate between the two? Dr. Nikita, can you hear me? Dr. Nikita, can you hear me?
Yes, sir. Yes, sir. I can hear you.
So,
Dif-
how would you differentiate between a bland portal vein thrombosis versus a portal vein tumor thrombosis? Because the prognosis is
Sir,
totally different.
by a clinical diagnosis, we can say the patient is suffering from portal vein thrombosis is only a rapidly rising in ascites.
No, the
It is a
question is
coincidental
the
finding.
question asked to you by Dr. Shani is that there can be a bland thrombus also, and there can be a malignant thrombus as well. So, how do you differentiate a bland thrombus from a malignant thrombus? Because this will have an implication on the management as well as the outcome. So, will CT scan help you? Will PET scan help you?
So CT scan will help me.
Yeah.
So in this particular patient, what was the diagnosis? Is it a bland thrombus or it is a malignant thrombus?
So it is a malignant thrombus.
Okay. Now, I possibly missed it. What was done in this case? How was this case managed?
So when the patient actually came to us,
you spoke about Atezolizumab and Biva combination.
Yes, sir. But we put a patient on a lenvatinib after discussion in a medical oncology unit.
Okay.
They preferably want to start on lenvatinib.
So hand foot disease was after the drug was started or before the drug was started?
So which disease you are talking about? I'm sorry.
You talked about skin complications, huh?
So skin complications happened in 2019 as patient was started on sorafenib that time.
Okay. So is lenvatinib also known to cause this syndrome, or it's not known to cause the syndrome?
It can, as I know, it can cause by sunitinib too.
Dr. Goenka, can I just step in? Yeah. So this case was discussed in the tumor board. In fact, my thing was slightly different from the tumor board. This thing. Number one, because the bilirubin was around 2, I would also like to consider the possibility of TARE therapy. I have not totally ruled it out, and I feel certainly she should be assessed for TARE. The oncologist was keen for lenvatinib, which was not started, and it was discussed with the patient's family. And the same side effects as of tyrosine kinase inhibitors was discussed. She was willing to take lenvatinib, which she will come for follow-up for consideration for TARE or these other drugs, bevacizumab and atezolizumab. So the family, the daughter was not keen to try these two, but she said she will come back to us. So at present, for the last almost 2 months, the patient has not come for follow-up.
What about immunotherapy? What was immunotherapy of the type of atezolizumab and bevacizumab also considered in this particular patient?
Dr. Goenka, it was offered. The daughter was not keen. I even gave her 1 or 2 studies to consider. It was told to her, she said she'll consider, she'll consult somebody, some other hospitals, and then come back to us. Right now, what we gave her a telephonic call. She's still on lenvatinib, but she's not come back for these kind of immunotherapies or for consideration for TARE, because otherwise her performance status is ECOG 1. It was so she is a good performance status. I certainly want to offer her immunotherapy or consider TARE also. She's not come back for follow-up.
Okay. One question to Nikita is, are we still into the MELD and child score, or you think there's some better way of looking at the liver status, liver function status? Are you aware of the albumin and bilirubin being taken as a criteria for deciding all these chemotherapies? Nikita, can you hear me?
So still we are using the Child-Pugh score and the performance status.
Yeah, but most of the oncologists now don't look at Child-Pugh score, and they look at the albumin and bilirubin, and there is a score which comes out from
So
albumin.
they are maybe they are considering the ABV criteria.
Yes.
In which, if the albumin is more than 4 gram and the bilirubin is less than 22 and the platelet is more than 1,14,000, they can considering it.
All right. So what was done for the gist?
So the gist was resected, a wedge resection was done.
Okay. Fine. So I think we have crossed half an hour time. Dr. Arvind, you want to move on to the next presentation?
Yeah, we'll move on to the next case. Thank you, Dr. Nikita, for a good presentation. We move over to our journal club. Dr. Suresh Chavla will be presenting the journal club. Over to Dr. Suresh Chavla, please. Dr. Suresh, please.
Yes, sir. I'm sharing my content. Can my slides be seen?
Yes.
Okay. Am I audible, sir?
Yes. Yes, Dr. Suresh.
Yeah. I would like to thank National Board of Examinations for giving us this opportunity. Good evening to all the faculty members and my dear friends. The topic of the journal club today is the article. My slides are not moving forward. Just a second.
From the presentation.
Just a second. Yeah.
And minimize the video and drag it to the top.
So the topic of discussion today is the article in the New England Journal of Medicine, which talks about adjuvant nivolumab in resected esophageal or G-Junction cancers, which is the Checkmate 577 trial. So what do we already know on this subject? So esophageal cancer is the 8th most common cancer worldwide, with 6th leading cause of cancer mortality. The esophageal squamous cell carcinoma is the most common form. However, the incidence of esophageal adenocarcinoma is on the rise. And in the Indian settings, the age standardized incidence rate is 6.5 per 1 lakh population in males and 4.2 per 1 lakh population for females, which translates into 47,000 new cases and 42,000 deaths annually. The reported 5-year survival rate for esophageal and G-junction cancer ranges from 5 to 30%, and most of these patients present in the advanced stage, that is stage 3 and stage 4. In this diagram, here we can see that the cervical esophagus, which is bounded superiorly by the upper esophageal sphincter and inferiorly by the sternal notch, typically is 15 to 20 centimeters from the incisors on endoscopy. From 20 to 25 centimeters from the incisors is the upper thoracic esophagus, which is bounded by the sternal notch above and the azygous vein below. From 25 to 30 centimeters from the incisors is the middle thoracic esophagus, which is bounded by the azygous vein above and the inferior pulmonary vein below. And the lower thoracic esophagus is from 30 to 40 centimeters from the incisors, wherein bounded superiorly by the inferior pulmonary vein and below by the lower esophageal sphincter. And on the right side is the Seawards classification for gastroesophageal junction tumors. The type 1 Seaward is the one wherein the tumor lies from 1 centimeter to 5 centimeter above the G junction. The type 2 Seawards is the one which lies within 1 centimeter from the G junction and 2 centimeters below the G junction. The type 1 and type 2 Seawards G junction tumors are treated as esophageal cancers, and type 3 Seawards, wherein the tumor lies 2 to 5 centimeters below the G junction, are treated as gastric cancers. This is the TNM staging of esophageal cancers, wherein TIS is carcinoma in situ, T1A is when the cancer is limited to mucosa, T1B is when it is limited to the submucosa, T2 is when it involves the muscularis propria. T3 is when it involves the adventitia. T4A when it involves the adjacent structures, that is pleura and pericardium. And T4B is when it involves the aorta, vertebral body or trachea. N1 is when there is involvement of one or two regional lymph nodes. N2 is when 3 to 6 lymph nodes are involved. And when more than seven or more than 7 lymph nodes are involved, it is N3. And M1 is for metastasis. Now, the point to be noted is that if it is T1B lesion where there is involvement of the submucosa, there is a 56% chance of lymph node metastasis. So this lymph node metastasis or involvement of the lymph node. Now, this lymph node status is an independent predictor of survival in esophageal cancers. Here is the diagram which talks about the standard of care in esophageal cancers. So when the disease is limited, that is T1 and T2, and there is no involvement of lymph nodes and no metastasis, resection can be offered to the patient. Whereas in case where there is a locally advanced disease, which is T3, T4, or involvement of lymph nodes from N1 to N3, but no metastasis, and if it is a squamous cell carcinoma, the patient is medically fit, one approach is to go for a neoadjuvant chemoradiotherapy. After that, restaging the patient and exclusion of metastasis and resection can be offered. If the patient is not fit for surgery or if the patient is not willing for surgery, then a definitive chemoradiotherapy can be given to the patient, followed up for every 3 months, and a salvage resection if there is recurrence of the tumor. For adenocarcinomas, we have option of perioperative chemotherapy. We restage the patient, and if the patient is fit for surgery or willing for surgery, surgery can be offered. Or else a neoadjuvant chemoradiotherapy can be given. Again, restage the patient once you have excluded metastasis, and resection can be done. So despite of having this standard of care, what is the problem? The problem is that the patients, those who achieve pathological complete response, have a 50% 5-year survival. So now let us consider what happens in those patients where pathological complete response is not achieved. In those patients, the 5-year survival rate is 37%. And even in those patients where there is involvement of lymph node, the median survival is 9 months and the 5-year survival is just 17%. So there is no established standard of care in the adjuvant settings. Those who have received chemoradiotherapy and have undergone surgery. In fact, the standard of care in such subgroup of population till this current trial was surveillance. So, thus, there is a significant medical need for treatment strategies in both esophageal and G-Junction cancers, which represents a major healthcare problem. And Checkmate 577 trial has evaluated the approach of using a checkpoint inhibitor, that is Nivolumab, as an adjuvant treatment. So, what is the significance of programmed cell death protein 1? So, it is a transmembrane protein which is primarily expressed on activated T cells, B cells, myeloid cells, and antigen presenting cells. So, this PD1 binds to its ligand, which is PDL1 and PDL2, and this leads to downregulation of the T cell activation. So PDL1 or PDL2 expressing tumors have been reported in 40% of the patients in gastric cancers and esophageal cancers respectively. And PDL1 expression is associated with the depth of muscle invasion, tumor size, and lymph node metastasis. And the overall survival of the patients, those who express PDL1 and L2, is worse as compared to the tumors which do not express PDL1. So the blockage of PD1 or its ligand might improve the survival of this population. So how does this Nivolumab act? Now, Nivolumab is a fully humanized IgG4 monoclonal antibody. So it binds the PD1 on the activated immune cell, and it will disrupt the engagement of the receptor with its ligand, that is PDL1 and PDL2, and it will abrogate the inhibitory signal, and this will further augment the host anti-tumor response. So what was the inclusion criteria of this study? So patients with squamous and adenocarcinomas, those who were stage 2 or stage 3, who received neoadjuvant chemoradiotherapy, had a complete resection, but had a residual pathological disease, which is either T1 or N1, had a good performance status, and all these patients were enrolled regardless of their PDL1 expression. The patients with cervical esophageal cancers were excluded. Patients with esophageal cancers who did not receive concurrent chemoradiotherapy prior to surgery, or who received only chemotherapy or only radiation therapy prior to the surgery, and patients with stage 4 resectable disease were excluded. Patients with previous malignancies, patients with autoimmune diseases, patients who required systemic treatment with either corticosteroids or other immunosuppressive medications within 14 days of trial drug administration, and patients who had symptomatic interstitial lung disease, HIV, and those who had received immune checkpoint inhibitors were excluded. So this was a randomized double-blind placebo-controlled trial. So after the neoadjuvant chemoradiotherapy and surgery, within 4 to 16 weeks, the patients were randomly assigned in 2:1 ratio to receive either Nivolumab, in which 240 milligram of Nivolumab was given every 2 weeks for the first 16 weeks, and then it was 480 milligram every 4 weeks, beginning at the 17 weeks up to 1 year. After randomization, the stratification was done on the basis of pathological lymph node status, whether it was positive or negative, then their histology, whether it was squamous or adenocarcinoma, or the PD-L1 status more than equal to 1% or less than 1%. The maximum duration of the trial intervention was 1 year, and the use of Nivolumab or placebo continued until disease recurrence, unacceptable toxic effects, or withdrawal of the consent. So from July 16 to August 2019, total of 1,085 patients at 170 sites in 29 countries were assessed. 794 patients fitted the inclusion criteria, and then they were randomized in 2:1 ratio, wherein 532 patients received Nivolumab and 262 patients were in the placebo arm. The median follow-up for this interim analysis was 24.4 months. The primary objective of this study was to compare the disease-free survival of Nivolumab versus placebo in subjects who fitted the inclusion criteria. The secondary objective was to compare the overall survival of Nivolumab versus placebo in patients fitting the inclusion criteria, to evaluate 1 year, 2 year, and 3 year survival rates, to look in for the safety of the drug, the distant metastasis-free survival, and patient-reported outcomes. So, if we look at the baseline characteristics, they were equally distributed in the two groups. The median age was 62. The ECOG performance status, if you look at that, 58% of the patients had ECOG performance status 0 and 42% had ECOG performance status 1. 66% of the patients in the Nivolumab group had stage 3 esophageal or G-Junction cancer. 60% of the patients in the Nivolumab group had esophageal cancer. The adenocarcinoma was the most common histological type, wherein 71% of them had adenocarcinoma. 70% of the patients in the Nivolumab group had a PD-L1 expression less than equal to 1%, and 57% of the patients in the Nivolumab group had a residual lymph node disease. So what was the disease-free survival in the overall population? So herein is the Kaplan-Meier estimate, where the blue line represents Nivolumab and the red line represents placebo. Here, the median disease-free survival was 22.4 months in the Nivolumab arm as compared to 11 months in the placebo arm. This p-value was statistically significant and the hazard ratio was 0.69. The separation of the survival, the Kaplan-Meier disease-free survival curves was sustained over a period of time. And the disease-free survival as per histology, so in patients with adenocarcinoma who received Nivolumab had a median disease-free survival of 19.4 months as compared to their placebo counterpart, where the median disease-free survival was 11.1 months. The response was more better in patients who had squamous cell carcinoma, where the median disease-free survival was 29.7 months as compared to 11 months in the placebo arm. In both the groups, if you look at the hazard ratio, it was 0.61 for squamous cell carcinoma and 0.75 for adenocarcinoma. So, in the subgroup analysis, what were the key observations? Now, more than half of the trial patients had a lymph node positive disease, which is a poor prognostic factor. But Nivolumab was associated with a significant improvement in disease-free survival, and there was a 31% reduction in the risk of recurrence or death. The median disease-free survival was twice as long in the Nivolumab group as in the placebo group, as showed before, 22 months versus 11 months. Now, the hazard ratio preferred Nivolumab across the pre-specified subgroups, that is squamous cell carcinoma and adenocarcinoma, and the pathological lymph node status. The adjuvant Nivolumab was similarly effective regardless of the tumor cell PD-L1 expression. And the hazard ratio for disease recurrence or death favored Nivolumab more in the subgroup of patients who had esophageal cancers than in the subgroup of patients with G-Junction cancers. Among the patients with adenocarcinoma, the median disease-free survival was 8.3 months longer than Nivolumab, 8.3 months longer with Nivolumab as compared to placebo. Also, the patients who received Nivolumab 10 weeks after the surgery, the magnitude of benefit was greater as compared to the patients who received Nivolumab within 10 weeks of the surgery. The risk of distant recurrence or death was 26% lower, and distant metastasis-free survival was 10.7 months longer with adjuvant Nivolumab. So here is the subgroup analysis. So if we see over here, the ECOG performance status 0 and 1, both the patients performed better with Nivolumab. The performance was better with a stage 3 disease as compared to the stage 2 disease, where the hazard ratio is 0.68 or 0.72, but both were good. The esophagus cancer had a better hazard ratio of 0.61. For squamous cell carcinoma, Nivolumab fared better as compared to adenocarcinoma, but hazard ratio was good in both the subgroup of patients. And the Nivolumab was effective across the expressions of PD-L1. And all these patients, those who had residual lymph node disease, had an hazard ratio of 0.67. This is the distant metastasis-free survival curve for Nivolumab versus placebo, wherein the median distant metastasis-free survival was 28.3 months as compared to 17.6 months in the placebo arm, with a hazard ratio of 0.74. So, looking towards the adverse events of the drugs, they were assessed throughout the trial treatment and during the follow-up. The serious adverse events was reported in less than 10% of the patients, those who were receiving Nivolumab. 86% of the patients, those who were receiving Nivolumab, received at least 90% of their planned dose. The most common adverse events were fatigue, diarrhea, pruritus, and rash. The majority of the adverse events related to Nivolumab were grade 1 or 2. Grade 3 or 4 adverse events occurred in 1% or less of the patients, those who were receiving Nivolumab. There were no grade 5 events in this category. The most common grade 3 or grade 4 Nivolumab related adverse events were pneumonitis and rash. And Nivolumab was tolerated well in this study population. This study also measured the quality of life indicators. And these were measured by using the EQ5D3L utility index score, its visual analog scale, and the FACT-E score. So what does this stand for? So EQ stands for the European Quality of Life, which includes 5 dimensions of quality of life, and each dimension having 3 limits. So what were these 5 dimensions? That was mobility, self-care, usual activity, pain or discomfort, and anxiety or depression. So each dimension had 3 limits and a score was calculated. Simultaneously, a visual analog scale was also calculated. And FACT-E stands for Functional Assessment of Cancer Therapy Esophageal. It had 7 parameters, that is physical well-being with 7 options, social or family well-being with 7 options, emotional well-being with 6 options, functional well-being with 7 options, and additional concerns with 17 options. Each option had a scale response from 0 to 4 with a recall of up to past 7 days, and depending upon the response, the score was calculated. And what did they found? There was a clinically meaningful improvement in both Nivolumab and placebo in terms of the EQ5D3L visual analog scale, but neither group had a clinically meaningful improvement in the FACT-E total score or the EQ5D3L utility score. So this indicated that the health-related quality of life was maintained during the treatment period. So the conclusion is that Checkmate 577 is a practice-changing trial in the treatment of esophageal or G-Junction cancers. It shows a first true advance in the adjuvant therapy of esophageal or G-Junction cancers, and NCCN in its guideline has included Nivolumab in its recommendation as an adjuvant therapy for esophageal and G-Junction cancers. The limitation is that the current publication is an interim analysis and the data on overall survival is yet to be released. The efficacy of adjuvant checkpoint inhibitor in patients receiving definitive chemoradiotherapy but no surgery, and patients receiving perioperative chemotherapy without radiotherapy is not addressed in Checkmate 577.
Thank you, Dr. Suresh, for an excellent presentation. Suresh, before we open the session for question and answer, just couple of questions for you. One is, why is there a high rate of such a high rate of recurrence in carcinoma esophagus? Can you explain based on the lymph node drainage, please?
Sir, that's because a patient who's having a T1B disease, that means where the involvement is just up to the submucosa. The submucosa is the area which has a very high lymphatic supply. So the moment the tumor is involving the submucosa, this will involve the regional lymph node. Hence, the esophageal cancers have a very high chances of lymph nodal involvement. Depending upon the area, then the regional lymph nodes are being drained. So,
Dr.
that,
Suresh, Dr.
yeah.
Suresh, the say lymphatic drainage of the thoracic esophagus in the middle part can be bidirectional. So you can have metastasis both in the cervical as well as in the abdominal area also. And
Yes.
important thing is that some of these lymphatics, they even from the submucosa, they cross through the muscle layer and join the draining lymph nodes. More important or worse still, some of these lymphatics directly open into the thoracic duct. So this is the reason for the recurrence rate in this disease based on the lymphatics. And secondly, my question is regarding the cost affordability. Do you think really in this country it will be a game changer? So your comments regarding the cost and a game changer in India in our setup.
Sir, actually, it's going to be a difficult thing in Indian settings because the DGCI approval for Nivolumab has been received for esophageal squamous cell carcinoma. But that doesn't solve the problem because these immune checkpoint inhibitors, once they get the approval from DGCI, still the patient will have to bear a cost of 16 lakh rupees for the treatment.
Okay.
And if there is now there is no DGCI approval for adenocarcinoma of the esophagus. So if there is a patient who has an esophageal adenocarcinoma and is planned for nivolumab therapy, he will have to shell out 60 lakh rupees for the treatment, which I think is still a very distant thing to be used in Indian settings.
Okay. Dr. Goenka, please. Dr. Goenka.
One clarification. You said it's an interim analysis.
Yes, sir.
Are they still recruiting patients, or the recruitment is over, or they are just analyzing them?
Sir, the recruitment is over. They are supposed to calculate the overall survival of the patients. So they have
calculated the Kaplan-Meier curve once again.
Yes, sir. I can do that. Are my slides visible, sir?
Yes. Go to one of the Kaplan-Meier curve.
Yes.
Now, here you see, I think this 42 months, this must be 42 months and 45 months.
Yes.
The number at risk is only 3 and 1, and at 45 months, it's 0 and 0.
Yes, sir.
So, how do we interpret this data? Because there is hardly any patient who is being evaluated at that time.
Sir, in this, the treatment given, the nivolumab was given only for 1 year to the patients. That is up to the 12 months, if we see. Yeah. After that, these patients were just followed up, and they were followed up for either death or disease recurrence. So when we say at 45, that means all these patients, those who were at risk, either had developed a disease recurrence or they had death. So in this in this study analysis, till now, 396 events had occurred, out of which 30 were deaths, and rest of them were disease recurrence. So by this, when I say 45 is 0, that means disease recurrence had occurred in almost all the patients, those who were in this group, whether it was nivolumab or placebo.
I want to know from you is that if the patient at risk is 0 and 0, then how is the two graphs of blue and orange still being widely separated? Is my question clear?
Yeah, sir. I got your question, sir. I don't know the explanation to that.
See, because if all the patients have either died or they have recurrence,
Yeah.
then that means that both the lines should be touching the baseline, isn't it?
Yes, sir. Yes, sir. But they are still widely separated.
All right. So
I would read about it, sir.
Yes. Okay. There's a chat box question. Why is it classified separately from CA esophagus and CA stomach? Seaward classification, which you talked about.
Yeah, because if we include the type 3 Seawards as esophageal cancers and subject them to the standard of care for esophageal cancers, the outcomes were poor. But if we manage them on the lines of CA stomach, the outcomes were better. That's why they included into the gastric cancers and not as esophageal cancers.
All right. Most of the Seaward 1 would be squamous cell carcinoma. Is it true?
Yes, sir.
And most of the Seaward 3 would be adenocarcinomas.
Yes, sir.
All right. So any other comments? I don't see any chat box question.
Dr. Mahesh, can I ask Dr. Suresh?
Yes,
Dr. Suresh, any thoughts regarding how can you decrease the incidence of esophageal cancer in India? Both the squamous cell and the adenocarcinoma. Any thoughts regarding how can you decrease the incidence of this widely prevalent disease? Because
sir,
I feel Nivolumab will be accessible or affordable to a very small minority of patients. So, any factors in your mind which can decrease the incidence of this deadly disease?
Sir, the only way by which we can help the patient in a cost-effective way is to have a surveillance program, in
Yes.
which if we try to have a surveillance program, do a timely endoscopy and detect the disease which is in a carcinoma C2, T1A or T1B stage, where we can give maximum benefit to the patient. But having said that, the surveillance program for esophageal cancers cannot be applied because the cost of applying a screening program and undergoing an endoscopy for patients for esophageal cancers is still not very clear, as we are getting more clear with colonoscopies for patients where we can detect polyps and remove that. So I think surveillance is going to be one thing which can help us to detect.
Dr. Suresh, surveillance will be especially relevant in case of adenocarcinoma in Barrett's esophagus, where you have a very regular screening. That should be done. You know the interval, you know the biopsies, you know. So that is one way to do a proper surveillance in Barrett's esophagus, so that you can decrease the incidence of adenocarcinoma. To
Yes.
decrease the incidence of squamous cell, obviously, you know the common factors, common carcinogens like alcohol, smoking, tobacco. So it needs to be taken up at a much, much wider and a bigger level. We sitting here in a room may not be able to do much as far as the Indian scenario is concerned. I think we have to be more vocal, and one should this has to be discussed at a national level, how to decrease the incidence. Dr. Goenka, last comments, please, Dr. Goenka.
We are in a very difficult situation. You talked about colonoscopic surveillance. Even that is not accepted in India because of the low prevalence of colonic cancers. So-called low prevalence of colonic cancers. I don't think anywhere in India we are doing universal screening at any age, for that matter. It's only the high-risk people who are offered the screening or surveillance program. Now, so far as the esophageal cancer is concerned, even more difficult because the pre-malignant condition and the polyp to malignancy sequence is not there in esophageal cancer. So one has to possibly depend more on early diagnosis than prevention. I think early diagnosis, even if we can reach an early diagnosis, that will be a great thing to do. And at least in high prevalence areas like North India, Kashmir, some of the areas in Northeast where the esophageal cancers are very common, I think education, both to the patients, population, as well as to the physician, is more important than anything else. I don't think we can develop a screening program or surveillance program for CA esophagus as of today. This is my viewpoint, but I think we need to educate people that they should come for early diagnosis. Arvind?
Yes, yeah. So I think we can conclude the session. The first case I have chosen because, in fact, it was quite rare to see a synchronous GIST and HCC. I had not seen it previously, so I thought we would present that. And this seemed to be an attractive journal article, seemed to be a game changer. So that is why these two things were chosen. Thank you for giving us this opportunity, Dr. Goenka. I thank you and the National Board for it. Thank you.
Thank you, Dr. Arvind, and both the DMA students for a nice presentation and good discussion. I think both the presentations were very good and it speaks about your training which is going on at Fortis in Mohali.
Thank you.
With
Thank
that,
you so
we'll
much.
session. Mr. Singh, we are back.
Okay, thank you so much. Thank you, Suresh. Thank you, Nikita. Thank you, Dr. Goenka. Thank you.
Thank you, sir. Thank you.
Thank you very much, Dr. Nikita and Dr. Suresh for the presentation. Thank you very much, Dr. Arvind Sahni and Dr.